Great. Hey, welcome everybody. Um, I am so honored to be presenting my friend and colleague, Dr. Anna Medelicus here. Um, and she's our guest speaker. And this endowed talk is generously supported by the Morris Dixon Family Endowed Chair for Global Child Health Education. That chair is held by Dr. Mike Dell, who couldn't be here today. He's sick. Um, and the family actually wanted to remain anonymous, but that made the donation. But it was a really wonderful donation and well needed here for global child health education. So I just wanted to say a little bit about Anna and I. Dr. Medelicus and I go back about 23 and a half years. I did the math when I started my fellowship here as a developmental behavioral pediatrician. And we became fast friends. We had our kids together. And it was really it was such a great time. And I want to say she's been one of the most amazing role models. And I rank her at the top really for kindness, most hardworking, most honest, passionate, and motivated people that I've ever met. She was the first pediatric global health fellow here. And I wanted to mention here, I showed this slide last year when Dr. Karen Olness was here. Dr. Karen Olness started the global health track. Here at the time it was called International Health Track. And Anna was a big part around after a few years of that. Anna came in as a fellow. We had a fellowship for global child health. So she was the first one. And Anna was involved with some of these things that Dr. Olness did. I just wanted to mention Dr. Olness because she was really such an inspirational person and still is with all these things. So I'm going to mention some of these things Anna was involved with just briefly because I wanted her to get to her big talk. One of the, I'm going to show this next slide here is Anna on her first global health trip. Was this with Dr. Olness? Yeah. Yeah. As a resident. Yeah. Yeah. She did a residency here too. Um, so yeah, I don't have time to list all of her accomplishments, but I do want to read her bio, which is very impressive. And even though it's her short bio, um, so she is professor of pediatrics at Baylor College of Medicine, where she serves as chief of the Division on Global Health and Immigrant Health. She teaches within the National School of Tropical Medicine and directs the Global Tuberculosis Program of Texas Children's Hospital. She serves as adjunct professor at the University of Texas Health Science Center, Houston's School of Public Health in the Department of Epidemiology, Human Genetics, and Environmental Science. She holds a prestigious Leibniz, did I say that right? Leibniz chair at the Research Center Wurzel in Germany, where she's also a member of the Clinical Infectious Disease Group of the German Center for Infectious Research, Clinical TB Unit. For nearly 3 decades, her translational research has focused on identification of Mycobacterium tuberculosis infection, which she's going to talk about today, TB diagnostics and prevention of TB disease, with a special focus on children and adolescents living with HIV. In recognition of her inspirational and pioneering spirit, she was awarded the Clara Southmaid Ludlow Medal of the American Society of Tropical Medicine and Hygiene in 2022. Since joining Baylor College of Medicine in 2012, Anna has collaborated with colleagues to develop research capacity and enhance the care and treatment of TB and TB HIV infected children, adolescents, and families living in over a dozen countries that are home to Baylor College of Medicine initiatives. So without further ado, I'm going to let Dr. Medelicus get her. I forgot to mention like over 135 papers. I mean, lots.
Thank you for thoroughly embarrassing
And a
me.
PhD.
All right. Great old picture of an amazing group of people here. That is on some of my slides too. So it's really great to be here this week. I'm excited to talk to you about the state of the world's children and really focusing on TB, really look at what the global impact of childhood TB is in the world, and to talk about opportunities to prevent, diagnose TB, improve outcomes for children and families. And being here is just tremendous. and really brings back a lot of memories. And I was here at an amazing time and really had an amazing group of mentors. So Dr. Onus, Dr. Kennel, God rest his soul, amazing man, Dr. Hellerstein, Dr. Niddleman, Huckin, Torgerson, Dr. Chardonnay. It was just an amazing time, really inspirational mentors. And I find myself so often, sitting in like a quagmire of academic pontificating, and I'll just say to my team, okay, stop. Like, what is a strategy that is best for helping children? And I'm like, oh my God, Karen's in my head, like eternally. And this is always what she would say, like, forget the politics and all this. Like, what is the right decision here for helping kids? That's what we're about. And then I got these pictures, some of these pictures from Marissa. So I saw this picture of him, like, I took that picture. And someone turned it into slide, and somebody turned it back into like digital media. And I took that picture of Karen. We went to an orphanage, an established orphanage for children with HIV. And so this was in 1996, and this was in Rwanda. And it was during the repatriation of Rwandan refugees back into Rwanda from the DRC. And that orphanage had received 300 new children that were unaccompanied children. And I actually gave grand rounds as the first resident to give grand rounds at this podium in this room almost 28 years ago on this topic. But this experience, really is what seared my commitment to working in global health. And, that gave me the tenacity, I think, in working with these mentors to do the work that I'm going to share with you here. I mean, Dr. Boda and this educational program, and those of you that are fortunate enough to benefit from it, should just, savor every minute of the experience you're getting here and what you're learning. And whatever you decide to go on and do in your life, it will make you more tenacious, a better advocate, a better pediatrician. Okay, so this is going to be fast-paced, interactive presentation. I'm going to ask you to scream some things out. So I'm going to start together with a countdown. And just like good pediatricians here, I want us all to count with our Mississippis. Okay, so 1 Mississippi. Stop. A child just died. All right, so the United Nations estimates that every 4.4 seconds, a child dies somewhere in the world. And in 2022 alone, 7 million children died, and 5 million of them before their 5th birthday. That's a horrible statistic. And we've been doing better. So this is data looking at the under 5 mortality from 1999, 2000 to 2021. And every region of the world it's declined. And this is the global under 5 mortality rate, which has dropped from about 98, about 38 in 2021. All right, so how are we really doing right now? We have no idea. Now, if I wasn't at the podium, I might use some more descriptors. So this is just one estimate of the impact of recent USAID freeze. And this is looking at programs affected by PEPFAR, the President's Emergency Plan for AIDS Relief. Every single one of these programs has been drastically reduced. We go down here to the bottom, PMTCT, the Prevention of Maternal to Child Transmission. 82% of programs have either reduced activities or canceled completely. And UNAIDS actually predicts that if PEPFAR is halted in the 90-day review period, we will be faced with the full resurgence of the HIV pandemic by 2029, with 6.3 million AIDS-related deaths and 3.4 million AIDS orphans within 4 years. All right. What about all of these orders allowing people to resume work? And I can tell you from my work, my teams on the front line, and from talking to people, and as reported just within the last week in the Times, these waivers are not making a difference because the money's not flowing. And these programs don't have extra budget to pay people. And so really, everything has really ceased. All right, so what's our strategy? Right now, our strategy is a shared blueprint for peace and prosperity for people and the planet now and into the future. Does anybody know what I'm talking about? You global health residents, what does that describe? All right, this is the Sustainable Development Goals. All right, so the Sustainable Development Goals are 17 interlinked objectives. And each one of these objectives has a goal. Some of these U.S. funding won't be able to support anymore, right? Here, look at number 5. I'm not even allowed to say the words for number 5. You know, climate change is also under that X. So goal 3 is good health and well-being. And what we as pediatricians are really interested in is target 3.2. So the target is that by 2030, we will end preventable deaths of newborns and children under 5 years of age, with all countries aiming to reduce neonatal mortality to at least as low as 12 per 1,000 live births and under 5 mortality to at least as 25 per 1,000 live births. And this is how we're doing in 2021. So you can see all these countries in the 2 light bluest colors have met the goal, but we still have a lot of work to do in many, many countries. And this slide actually highlights 54 countries that have been defined as needing accelerated action, because they're not making progress towards these goals rapidly enough. And what this slide does is actually shows the under 5 mortality and the proportion of it that's neonatal mortality, defined as death in the first 28 days of life here in the orange, and then the under 5 mortality, which is from month 1 to month 59. Okay, and so what I would say to you is, we actually know how to prevent all of this blue, and you guys should be learning about this stuff. And I just hear Karn in my head again, right? So we know the tools: growth monitoring, oral rehydration salts, breastfeeding, immunization, female education, family planning, food supplementation, providing essential drugs for the treatment of common ailments. These things work, they keep children alive. So why isn't it happening? All right, this is a cool website if you're a data person, and this is the UN Interagency Group on Child Mortality Estimates, and you can go in and you can ask it to make you graphs. So I made this graph for this talk to actually zoom in a little bit on disease-specific mortality. All right, so this line, they're doing pretty good, huh? Anybody want to guess what disease that is? It's malaria, right? So lots of mosquito impregnated gnats placed all over the world by USAID. What's this one? All right, so it's HIV, PEPFAR. And this slacker is TB with these very, very wide confidence intervals, because we don't even really know what the estimate is. Okay, so what is our best guess about the child TB global burden? I said about 10 million people combat TB each year. Of those, about 10%, 1.1 million, are children. Of those children, about 226,000 will lose that battle and die. And I want to zoom you in on this fact right here. 96% of those deaths happen in children who never get treated. All right, how is that possible? I said, this is some modeling work done by Pete Dodd in the UK, and he actually looked at causes of death in treated versus untreated children stratified by age and HIV status. So you can see here, 80% of all death happens in children under 5. And on this side of the square, 17% of all deaths happens in children living with HIV. And then he looks at death in treated versus untreated, treated versus untreated, and arrives at the summary estimate that greater than 96% of children who die from TB never get treatment. If there's anything you remember from my talk today, it's that one advocacy fact. And it's completely unacceptable. All right, so how do we fix this? And I laugh because I have a snarky team member who's adult infectious disease trained. Of course, we need to improve the diagnosis and treatment in adults so they don't get the kids sick. That's not the right answer. So what is it? Is it prevention? Is it diagnosis? Is it treatment? We're going to explore all of these. We can do better in every single area. And I'm going to start with prevention. And the reason is because of this side of this chart, 7.5 million. Every year, 7.5 million children become infected with Mycobacterium tuberculosis, the causative agent of TB. Every single one of those children infected has the ability to progress to TB disease. And that's what TB disease looks like in a child. And at this moment, there's 53 million children in the world who are infected with Mycobacterium tuberculosis. Every one of those children could stay healthy, and we can prevent disease in them. And we have the tools to do it. All right, let's start with BCG. BCG is the oldest vaccine in the world, right? And actually, it was developed in 1921. Actually, it was developed a little earlier than 1921. It was developed as an experimental vaccine for cattle to prevent bovine tuberculosis. And it was first administered to newborn in Paris in 1921. 100 years later, in 2021, 88% of the world's newborns have gotten BCG vaccine. And it's been given to more people than any other vaccine in the history of mankind. And it has saved millions and millions of lives. How good does it work? This is new data by Leo Martinez at BU. If you like this kind of modeling, and Leo's amazing, just Google, PubMed search him, great stuff. So Leo gathered data because he's a nice guy and everybody wants to give him their data. So data from 26 cohorts in 17 countries looking at 69,000 participants. And he actually showed that the adjusted odds, so the ability of BCG to prevent TB disease, the adjusted odds is 0.82. So reduces the risk of TB by 18% in all ages. But then he looked at age stratified data. And what you see here is all of that effect comes from children under 5. And so reduces the risk of disease by about 37% in children under 5. He actually did subgroup analysis where he looked at what is the protective effect if you know that the person has Mycobacterium tuberculosis infection. And the protective effect actually is, it's effective actually in the 5 to 9-year-old group also. All right, so how did BCG save so many lives? And this doesn't sound like that great of a vaccine, right? Okay, so BCG has this survival benefit, and we still don't understand why. Probably has some epigenetic changes that actually do good in the host. But so it reduces all-cause mortality. And this is more data from Leo, where he looked at 4 studies that actually had death, all-cause death reported, 18,000 participants. So what you can see in children, the adjusted odds ratio protecting against all-cause mortality is from 0.13 to 0.25. So really pretty amazing all-cause mortality effect of BCG. Okay, we have about 18 vaccines in the pipeline, and M72 is the leading vaccine. And what we have seen from early data on this is if you give this vaccine to people who you know have Mycobacterium tuberculosis infection, over 3 years, it reduces the risk of progressing to active disease by 50%. Okay, so I want you to remember that. All right, so now we're going to just talk a little bit about magic bullets and heroes. All right, so how many people know who Edith Lincoln is? Awesome. She's like my TB hero. So Edith Lincoln was a pediatrician. He worked at Bellevue Hospital in New York City in the pediatric chest clinic. And from 1930 to 1946, she treated almost 1,000 kids. Her case fatality rate was almost 22%. And we know this because she took meticulous handwritten records and she calculated this. And passionate physician taking care of her patients, 22% of them dying. And in 1952 to 1953, she took care of 129 children. Her case fatality rate dropped to 0.5%. What was her magic bullet? It was isoniazid. And she actually started using isoniazid, and she said isoniazid needs to be considered not just for every child with active primary pulmonary TB, but also for children who've just converted their tuberculin skin test, even when their chest x-rays are normal. And she was the first person that realized that isoniazid could prevent TB. And she was a true pediatrician and advocated and went to the U.S. Public Health Service and got them to do all those really cool studies in Bethel, Alaska, and in other communities with a lot of TB to show that isoniazid could prevent disease. People ask, does this work in modern times? We have HIV, all these new pressures. This is actually some data from my first R01, which I got while I was assistant professor here. And this was work that was done in the Western Cape in South Africa. It was a diagnostic study looking at MTB infection that we followed kids longitudinally. But just recently, I did some data looking at observational findings to look at the protective effect of isoniazid. So, so we enrolled 600 children who we had identified someone in their home with TB. We went to the homes to see if they had TB. And then we knocked on the door of a home next to them. And this was in Khayelitsha, which is an informal settlement on the outskirts of Cape Town. So we recruited about 400 kids from those neighboring homes. Actually, about a quarter of them said, oh, yeah, we have TB here too. And then we diagnosed TB. So 8% of the children actually had TB at that point in time, prevalent TB cases. Everybody else who didn't have TB, we referred them to get TB preventive treatment, which was not something that they were doing at the time in South Africa. So only 31% of the children who could have gotten preventive therapy got it. And then the children stayed in the study because it's part of the longitudinal diagnostic study. And we took care of those kids. Another 3% of the children actually developed TB during the course of the study. What we were able to show from this observational data is that isoniazid preventive therapy reduced the risk of those children progressing to TB by 82%. And it worked the most in the groups of kids you would expect: young children, children living with HIV, children who knew that they had contact, children who had proof of an M. tuberculosis infection. And then we went one step further and we calculated the number needed to treat. So this is how many kids do you need to treat with isoniazid, which at the time, a 6-month course of isoniazid cost about $20. How many kids do you need to treat in order to prevent 1 case of TB? So you can see here in children less than 5, 19. And in children living with HIV, 15. It's incredibly effective. Leo looked at this again in his cohort. This is data from studies that included 600,000 patient years of follow-up. All right, so this is the number needed to treat on the y-axis. And what he does here is he looks at the overall population stratified by young children, older children, adults, all ages. Then he looks at TB high burden countries, TB low burden countries, and sees the number needed to treat ranging anywhere from about 15 to about 40, really small. All right, but this data is in people who he knows have Mycobacterium tuberculosis infection, either by positive tuberculin skin test or by positive IGRA, interferon gamma release assay, so quantiferin T-spot. What if he doesn't know their infection status? And the picture really changes. Actually, so the number needed to treat in the low burden setting jumps really high. So here in the United States, if we treat everyone, and we treat a lot of people, but if we treat people based on their infection status, it's more cost effective. And then here in a low burden setting, so many people are infected, you just treat everyone. You don't necessarily need to use tests. Other good news is that TB preventive treatment regimens have gotten a lot easier. So this is Edith Lincoln treating with isoniazid 18, even 36 months in some of those U.S. Public Health Service studies. And here we are now. We treat, in Houston, we use 3 HP. So it's isoniazid rifapentine once weekly for 12 weeks. We use video direct observation of preventive treatment. The parents open up an app and send the video in, and we see the kid take the pill. Yeah, and it's like almost 100% clean. You're actually using video apps overseas too. So it's amazing, and we can do this. So this is really cool. In 2018, the UN had their first ever high-level meeting on TB. I got to go. One of my friends at UNICEF got me in. It was really cool being on the floor watching the UN. But so they said, we're going to prevent TB. And they set a target of 30 million. And I said between 2018 and 2022, we're going to treat 30 million people with TB preventive treatment, including people living with HIV, household contacts under 5, which we always used to treat, and then other people in the household who are older but still have risk for TB. We achieved 52% of that target because the HIV world hit their goal twofold. So in children under 5, we hit half the target. And in this new group, we got 10%. We're doing better over time. And you can see from this graph here in 2022, you can see this new group of eligible people for preventive therapy. We're starting to capture more and more of them and more of the under 5s and less of the people living with HIV because the guidelines have changed. We're going to move on to diagnosis and screening here. So I say to people oftentimes that actually changing historical paradigms for child TB has been harder than getting girls to go to school in many places. And this is this conceptual framework that people use in TB all the time to talk about transmission. So you start here at the top and you have a person who might or might not be susceptible to TB, might or might not get infected. And then they go through, maybe they get sick and get symptomatic. Maybe the healthcare system actually realizes they have TB and treats them. You know, I start working during my K, go to South Africa, and I'm talking about prevention. And, you know, my mentors there are looking at me and they're like, we have so much disease to prevent, disease to treat, you know, down here at the bottom of the cascade. We can't begin to shift resources into prevention. And we can't even think about trying to find other cases. Okay, so they're relying on what we call passive case finding. This is a picture of our clinic in Eswatini. Every week we have a mom who will show up like this with a baby and say, you know, my baby's not growing, they're really sick. I've been all over the place to all these clinics. This is in a country where 1 out of 4 people is living with HIV, and 60% of the newly diagnosed TB cases are HIV associated. And people aren't thinking to look for TB or HIV in this child. And it takes a clinician like Godwin here to actually say, maybe your baby has TB, and look for TB. So what's the result of this? The result is this infamous TB case detection gap. So here we go again with the broad swath of estimated TB cases in the world. And this line here is the number of notifications or the absolute number of cases reported. And the difference between these two lines is the case detection gap, which we were narrowing a little bit until COVID. And then we started to catch up. We don't really know what to expect is going to happen next. But you can see here in 2022, about a 25% case detection gap. This is WHO data looking at gender stratified data, women and men, and age stratified data. We come down here to the bottom and what we see is that in children, the case detection gap's about 56%. And in children under 5, it increases to 65%. This is part of the reason why 96% of children die without ever getting treatment. So how important is it to find these cases and find them quickly? So this is a really amazing story. Flashback, 1930, Lübeck, Germany, small little town outside of Hamburg. And they're like, we're going to do this great neonatal vaccine campaign. And they get some BCG from Calmette at Institut Pasteur and store it. And it gets infected with the Kiel strain of Mycobacterium tuberculosis, very virulent strain. And they proceed to orally vaccinate all the newborns with live Mycobacterium tuberculosis. So 84% of the children develop TB, 37% of these newborns die. 93% of them die in the first 6 months. That's how fast kids die from TB. And this is orally introduced into their GI tract. This wasn't breathed into their lungs. Okay, so we need to find cases fast, and we do that by active case finding. It's what we do in the United States. And this is a picture of our team in Eswatini on a project that was funded by the UN. And so the team going to the homes of newly diagnosed TB cases, asking people if they have symptoms, helping children and people give a sputum specimen, and taking that specimen to new diagnostic machines that were introduced in the country. In the first year of that project, we increased the detection of bacteriologically confirmed TB in children by 32%. And we were able to show that the risk of TB in children living in a home with adult case is almost 1,400 per 100,000. This is the metric we use for TB incidence. Does anybody know what it is global average. It's 131. So yeah, we should be looking in the household for TB in children. In the US, it's like 2.7. Right, so we have much, much, much more disease in a household. And then, of course, in the household, the young children, children living with HIV, symptomatic children, children sleeping with their mom who's coughing TB up, are at much greater risk of having disease. And if the household's affected by TB, the odds of finding a case is 1.4. Now, this cool work from Jason Andrews at Stanford actually looks at where else does TB happen, transmission happen. So he looks at age stratified risk of getting TB in all these different households, different settings. And actually what he shows is at best, maybe 30% of TB that children get is transmitted in the household. So we really need to start looking outside of the household, looking at public transportation or schools. And this is a new study, was published as part of the doctoral work for Anka Vassiliou, who actually joined our team as a postdoc. And they did a randomized clinical trial across 20 clusters. So these clusters included district hospitals and primary health centers in the Cameroon and Uganda. And they compared interventions. So these were interventions for screening and management of the contacts in a community-based approach versus the standard of care, which is a facility-based approach. No matter how they looked at it, community-based care worked better. And what they actually showed was that if you use the community-based model, children were 3 times more likely to initiate and finish their preventive treatment. Okay, we're going to move on to diagnosis here. All right, so this is your first question of the presentation. So this is a smear and those are red snappers. And this is, I'm going to have a drink here while you all read this question and think about what answer you want. Okay, how many say A? Show of hands. B. Couple B's. C. All of the above. None of the above. It's actually C. So the crux of the matter here is that, and you all learned this in med school, children have paucibacillary TB. Now I'm going to tell you children have paucibacillary sputum. And this is how much Mycobacterium tuberculosis is in their sputum. And all of the diagnostic tests that we have are developed for adult TB, which has a lot more MTB in the sputum. And so the lower limit of detection is not low enough to capture the small amounts of TB that children have. So this is why children have smear-negative TB, and for many, many decades were not counted. So how do we diagnose TB in children? And my old mentors would be very happy to know that we do it based on a really, really, really good history and physical exam. And so actually a history of cough, growth failure, fever, decreased playfulness. Physical exam actually doesn't give us a lot of information. The vital signs are normal, a chest exam is normal. Sometimes you might find a differential diagnosis, but does anybody know what the most important thing of physical exam is, what I'm going to show you next? Anyone want to guess? These Road to Health cards. Failure to thrive. Failure to thrive is huge, and we see children losing weight and failing to thrive as one of the first signs of TB. And this is classic seminal work in TB done by Ben Murray when he was in South Africa. He's in Australia now, really brilliant clinician and clinical researcher. And he said, what if we combine symptoms? And he said, if we combine very, very carefully elicited, persistent, unremitting cough, this is not asthma, and we actually look at failure to thrive and decreased playfulness, the positive predictive value of those 3 criteria together is actually 90% in children less than 3 years of age without HIV infection, 82% in older children, and works terribly in the context of HIV. Okay, what about chest X-ray, the cornerstone of our diagnosis? Next question. Which of the following is true of chest radiography for the diagnosis of TB in children? 39% sensitive, 74% specific. A normal chest X-ray does not rule out TB. All of the above, None of the above? No, it's all of the above. All right, so this, does anyone know what this is called? What you can see if you're fortunate enough to get an AP in addition to your lateral in a TB hybrid setting, it's donut sign. So it's hilar lymphadenopathy. And if you actually have hilar lymphadenopathy, your chest x-ray increases to 60% sensitivity and 59% specificity. There's a big, huge movement now to use computer-aided detection with digital radiography, which we actually have digital radiography available. And the computer-aided detection is actually recommended as a screening tool in adults. We have almost no data in children right now. We're gathering it, though. CT works better in chest x-ray. We don't have CTs except in places like Cape Town where they use them for studies. And actually, ultrasound is really emerging as a really, really powerful tool. And they have Foch ultrasound, which is this like rapid point of care ultrasound that a medical tech can use to look for lymphadenopathy in the thorax and the abdomen. So in Malawi is where this started. And it's really powerful because you have so much lymphadenopathy with HIV-associated TB. All right. So what the WHO has recently recommended is called integrated treatment decision algorithms. And our team actually wrote the chapter in the operational handbook on this. So there are these algorithms. We actually have a point system, and there's an algorithm A and B. Algorithm B doesn't actually even have chest x-ray in it because we still have so many settings where chest x-ray isn't a tool. But once a child achieves a score of 10, they achieve the score you need to say that child, the probability of TB is high enough that you treat that child. Okay. What else is going on in diagnostics? So does everybody know what GeneXpert is? All right. GeneXpert is an automated NAT, nucleic acid antibody test, and it's cartridge-based PCR. So it's like a little Keurig machine. And in the lab, it takes 2 hours to process the specimen, and it detects the presence of Mycobacterium tuberculosis and rifampicin resistance. Okay, so the first generation was called MTB-RIF, and that's the gray column here. And the second generation is called Ultra, and this is a Cochrane systematic review that our team did to look at the performance of first versus second generation cartridge in all these different specimens: sputum, gastric aspirate, stool, which we can always get out of a child, and nasopharyngeal aspirate. And what we showed was the cartridges worked the same. There was also no statistical difference in the accuracy of this test for sensitivity or specificity for all of these specimens. So this led to informing the new guidelines for WHO, which say that the initial diagnostic test for TB and the detection of rifampicin resistance should be Expert Ultra, and it should be used on sputum, nasopharyngeal aspirates, gastric aspirates, or stool, rather than smear microscopy and rather than phenotypic drug susceptibility testing. So this is the little plate that we use with the culture growth, right? So this is what we're moving to. So this is why I said postbacillary sputum. We're finding MTB in stool. And so our team was funded to do this study looking at an in-house stool-based quantitative PCR to look at its ability to help with diagnosing TB and also monitoring treatment. We implemented the study from 2020, September to February of 2023 in Eswatini, Mozambique, and Tanzania. It was a miracle that we actually got the study done because this was dead smack in the middle of COVID, right? I mean, the teams were amazing. So this is the first paper actually published from this work. And we actually did subgroup analysis on participants greater than 10 years of age. And so we had 268 participants who either had microbiologically confirmed TB or they were clinically diagnosed with TB, 55% living with HIV, compared to 140 controls. We did a bunch of comparisons compared to what we call a fantastical composite reference standard. So this is like what's perfect? We know none of these tests are perfect, right? Smear's not perfect, culture's not perfect. What if you compare this to every single test you have because somebody had 3 smears done, right? But in the end, so pulling this all together, what we actually showed was that our in-house qPCR actually performed better, and our in-house qPCR on stool performed better than stool on GeneXpert and performed equally as well as sputum assessed by GeneXpert. And then we actually looked at additional yield. So additive yield, so these are people who had all the tests done, and these are head-to-head comparisons of positivity rates for people who were treated for TB disease. Somebody said they have TB. And what you see is that compared to stool expert culture, so sputum culture, or sputum expert, the stool qPCR detected a confirmed disease in an additional 17 to 21%. So, if you have a patient who you really think has TB, but you're not sure, and you want another test, you can do more tests. And doing these different tests on different specimens may allow you to confirm disease. So with this study and some funding from the German government, we also introduced gene sequencing into Eswatini and actually looked at the ability of using stool-based sequencing to detect drug resistance. Okay. So this work, a lot of this work was done by so this is Tara Ness, she was a PEDS global health resident in our global health track, and then did ID fellowship, and she just joined faculty in July, and she got the PEDS St. Jude's Young Investigator funding award to help bridge her to faculty position. So what we were able to do is extract MTB DNA from stool, and then evaluate it using D-Plex, which is a targeted next generation sequencing kit on the Illumina sequencer. We were able to detect mutations to 14 second-line drugs for TB. And this compares the heat map of the stool testing on D-Plex compared to good old-fashioned phenotypic culture growth. You can see very, very different picture because so many things cannot be detected on traditional culture. So why is that important? So go again, our wide swathed TB estimates. So this is the TB estimate of MDR, multi-drug resistant, rifampicin resistant TB in the world. Blue line is the number of cases reported. Red line is the number of cases treated. So we're treating everyone we find, but we have a greater than 50% case detection gap for drug-resistant TB. And I finally started to look, okay, so this is the absolute number of people treated. And then in 2018, they said, well, let's look at this age stratified. This little teeny red line at the top of the bars are how many children are getting treated for drug-resistant TB in the world. And this is because we can't grow culture out of children. But if we can detect drug resistance from stool, we can actually open the door for children to actually get treated for drug-resistant TB. It's about how do you make all this happen? Right, so we know how to take care of TB, but we're not doing it. And this is all implementation science. So this is a project that we're doing actually in 5 countries: Eswatini, Lesotho, Malawi, Tanzania, and Uganda. And so UO1 in partnership with the CDC. And so this project looks at people living with HIV that come to one of the Baylor clinics for routine care and treatment. So 6,500 individuals crossing that threshold, and we're looking at innovative screening and diagnostic tests in these people. If they screen negative, then they move to the second aim, which actually offers them preventive treatment and is differentiated service delivery. So we say, pick what kind of preventive treatment regimen you want. And then we have an embedded RCT looking at enhanced adherence support with bidirectional messaging to see if we can improve initiation and completion rates in that population. The third aim is cost-effectiveness modeling, looking at the cost-effectiveness implications of the diagnostics or the preventive treatment. And the fourth aim is an Echo Hub. So it's a web-based learning platform to promote best practices and disseminate information. We're hoping we're able to finish this study. when we were out of communication with our CDC colleagues for quite a while, they're able to talk to us again with just for program management, but we're not actually allowed to talk about implementation. So I'm going to finish up here really quickly on treatment. We have some really exciting new stuff for drug treatment in children. We actually had a pediatric study published in the New England Journal. This was a publication looking at the SHINE study, which was an open label phase 3 non-inferiority RCT comparing traditional 6 months of treatment to 4 months of treatment, shortened treatment. So, you know, right, so normal TB treatment is 2 months of your initiation phase with 4 drugs, right? So rifampicin, isoniazid, ethambutol, pyrazinamide. And then you have this continuation phase of just rifampicin and isoniazid. So the shortened regimen knocks off 2 months of the continuation phase, and they actually use these really cool fixed dose combination child-friendly tablets that are not available in the United States, are only available from the Global Drug Facility, and they're dispersible in water, and they taste really good, and they're scored, so the moms don't have to try to break up a little pill to get the right weight-based dosing. So however they cut this cake, they showed no inferiority. And so their primary endpoint, their primary endpoint analysis up here was a modified intent to treat analysis. But you can see here, no difference between shortened or the longer treatment. So the guidelines now are you can use either one. Well, that doesn't really make a lot of sense, right? But the reason for that is, like we see oftentimes in clinical trials for children, I'm looking at Greg, is because, you know, they were very scared to do this study in children, and they picked a population of kids who weren't very sick. And they had what they called minimal TB. They had smear negative. They didn't really look sick on exam that much. And their chest x-rays weren't bad. And then WHO said, okay, we're going to do this. And we don't really know how it's going to work in kids who are really sick. So we're trying to monitor that, and they're asking everybody to gather data, unfunded data, and share that data collectively so we can try to figure it out if the guidelines are actually working. All right, what about drug-resistant TB in children? These are the guidelines. You can do all these different things. And we have moved forward to have non-injectable regimens. So the injectable drugs are what cause all the ototoxicity and other very severe adverse effects. So we actually have non-injectable regimens. We started, and I'm a co-investigator on this work. It's out of Hopkins, looking at shortened treatment for MDR-TB in children. We recruited the first 3 subjects and got a stop work order. So we have 3 children recruited in Uganda at the clinic that Karin started, we can't continue right now. Okay, so the WHO guidelines, really just summarizing this, we reviewed a lot of these treatment algorithms. We can use Ultra on stool. We can use a 4-month shortened regimen, all oral medications. We can use bedaquiline and delamanid, which are the 2 new drugs we have in TB. There's actually a shortened regimen that you can try for TB meningitis. And this last guideline I'm just going to talk about for the next few minutes, which is in TB high burden countries, WHO is recommending decentralized, family-centered, integrated services to improve case detection and the uptake of TB preventive treatment. What does this mean? Okay, so these are hot topics to think about if you think you want to work in TB. So maternal infant TB. This is a picture from the OBGYN unit at Port Moresby Hospital in Papua New Guinea, where our team's been working for over a decade. We have a UN-funded project, which is still happening, that is looking at TB screening in pregnant and postpartum women. There's probably about a 35% case detection gap in pregnant women. The woman that was spearheading this work is at USAID. She's been fired. This was guidelines that were released on management of an infant born to mother with TB. So They have guidelines for low burden, high burden settings. They started out to do a systematic review. They couldn't because there's just no data. So they have consensus opinions out there about treatment of a newborn. All right. Next is post-TB sequelae. There's a lot of really cool emerging data saying that even if you complete TB treatment and somebody says you're cured, you have long-term consequence of TB, and it's probably epigenetic changes. And it's one thing that everybody seems to remember, which is easy. In the 5 years after a person successfully completes TB treatment, they have a 3-fold increased risk of death from cardiac causes. Okay. And this is some cool work, actually, if you're into this kind of modeling, looking at lifetime burden due to TB disease, and it looks at life years lost and disabilities. You can see children here under 5 have the biggest, hugest columns, right? So this red is, for instance, life years lost from disease, and the blue is disability. If you come down here to disability adjusted life years, you can see that in data from 2019, the children under 4, as a result of TB, will have lost almost 12 million disability adjusted life years. And there's data from Kaiser Permanente in Northern California. This is United States data that actually shows the average life years lost for a case of TB in an American in Northern California is 7 years. So keep an eye on this. HIV-associated TB is still a problem, and people are still living with HIV and dying from TB. So almost 40% of deaths in people living with HIV are due to TB. We have not had a lot of data in children, and this is, I think, probably related. So Alex Kay is my associate program director, and he actually just got funded for an NIH DP1 award, which is like, he had a K award. That is what this work came out of that I'm going to tell you about. And he just got an NIH DP1 Catalyst Award that hopefully he will be able to continue to implement. So this work actually looked at 800 children and adolescents living with HIV who at the time of TB diagnosis had never taken antiretroviral therapy. So they were ART naive. And there's big debate of like, when do you start TB treatment in these kids? Are they going to get IRIS, right? And they're going to die if you start it too early. So what he was able to show is that the kids who started ARTs less than 2 weeks after their diagnosis had no difference in their survival than the children who started later. So, start them while you have them there in your clinic. Because if you don't start, the 1-year mortality is 3 times greater for not ever starting ART in these children. All right, and then my last topical area, standard of living. And so, I was a medical anthropology major at Case in the 1980s when I went to undergrad. And Denise took me to the restaurant last night where I was the hostess in 1989. I walked up to the podium and was like, I used to be the hostess here in 1989. They were all like, where did this lady come from? But, TB is a social disease with medical implications. We know how to treat TB, and not treating TB is our biggest failure in medicine. And so what does this mean? This is the global TB incidence map. All right, so these dark areas have more TB. This is the International Monetary Fund per capita income map, right? And it's same color densities. And this, you guys have seen these kind of maps, so this kind of timeline. So this is a timeline actually from Denmark. Look, because we have so much great data, right, in these countries in Europe. So looking at 150 years of TB incidence decline. This is like first BCG vaccine was here. So what happened before that? Yes, health, hygiene, food, nutrition, right? So this study just was published. A study, this is called Rations, an amazing study in India where they said, we're going to randomize households of TB cases and give them food baskets. Okay, so they gave food baskets to half the households with 1,700 calories per person and 9 grams of protein. And they reduced the risk of progressing to TB by 50%, the same as our front-relating vaccine, by feeding people. I said WHO has this big, huge new campaign about how are we going to do nutritional supplementation, give people food baskets, and they brought World Food Program in. And CDC has an RFA out right now, which is the RFA I have due on Monday, trying to look at RCTs for food supplementation. We're hoping the study sections actually meet because in the last month, 37 of 45 study sections were canceled at the NIH. So World Food Program came and said, you want to give people baskets? Like we're doing cash transfers. They just give people money, commodity transfers, and they're even doing Bitcoin in some places. And they're like, we don't care what the people use the money on. If we give, and it's very paternalistic for you to want to control what people use the money on. You give them money, their home gets better, and there's less poor health. Okay, so in summary, 7.5 million children get Mycobacterium tuberculosis infection every year. 250,000 children die. All of these deaths are preventable. And we actually have the tools and the strategies to prevent these deaths. And when we don't use our tools and the strategies we have, these diseases come back. We have TB outbreak in Kansas City and good old Texas, where I work now, with massive measles outbreak in West Texas. So just acknowledgement of all the amazing partners and U.S. government funders. We have 2 training grants from Fogarty International Center, 2 research training grants right now that will probably not be continued in their funding. So really amazing acknowledgements for all these partners. These are the faces of team members of ours all over the place in Africa, Papua New Guinea, the team in Houston. Karen, I'd love all the babies. And just really want to thank all of you for listening and really encourage you all to follow us and anyone else you want to follow on Blue Sky. Oh, there was a place that I was supposed to be able to see I lost it. Text messages or questions online. Oh, here's the chat. No questions in the chat. Okay. We don't have much time, but I'm very happy to answer
Yes,
questions. I'm
thank
not
you.
offended if
Is
folks
this
have to
working?
leave.
Is
And
this
I will, oh my gosh, I'll be here. My senior resident when I was an intern.
That was the best Grand Rounds. I'm sorry to all the other Grand Rounds people, but no, it was really this. Thank you so much, Anna. This was an amazing talk. I'm really, 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 really impressed. Even more than I was impressed before. Like, no, it's just incredible what you're doing. This is such important work. I mean, unbelievable. And how just bringing in like all of the important things in the like nutrition, poverty is a big driver for a lot of infectious diseases out there. So we are opening this up to questions. And I will bring the microphone to you so that the online people can hear.
Thank you. That was a very eloquent talk. It was excellent. I'm wondering, in today's political climate, if there, oh, okay. In today's political climate, what considerations or how do you guys plan to combat like finding funding to keep these projects going? Like, what areas are you starting to look in to like overcome what's happening in America?
So there's an app that you can get that actually will tell you, help you figure out what your messages are and who to contact, who your representatives are to contact. And phone calls are much better than sending messages. So you can get on all their websites and send the messages. We did a talk yesterday. You know, my 3 representatives in Texas and where I live are Abbott, Cruz, and Niels. And I sent Niels a message on his website about USAID funding, and he sent me back, one of his staffers sent me back a message that was about this completely debunked accusation from Musk saying that USAID was funding poppy fields for heroin production in Afghanistan to fund Al Qaeda. That's what my representative sent me back as, or shutting USAID down because they are drug pushers. So, you know, I mean, you can, you know, there are specific representatives who are more pro some of this stuff. And, you know, you can try to call them and push them to flip. And if you're lucky enough to have one of them in your district or on your 5 Calls app, you might actually have an influence. You know, I mean, I can go on and on. But, you know, if you look at the New York Times yesterday, they published a grid of where the funding cuts are going to be. And they're mostly for Medicaid and Medicare. And it's a really, really small amount from NIH. So how's that helpful? I mean, there's a lot of dialogue about, should we really be doing a 15% cap or not? And like, where do we come up with 15%, right? And even like EDCTP Europe does 25%, Japan does 30. Where, you know, maybe we should be doing more than that. So, I mean, if we can at least, and then we're going to have a reduction of the NIH cap. And they're not going to rest unless that happens. But if we can maybe make it a little higher than 15%, maybe you guys will have a spot for fellowship. I mean, this is real.
Mhm. Any more questions? Are there any online questions, Robert? No. No online. Okay.
Well, thank you
Thank
all for
you.
being here. Yeah. Thank you for advocating.